Greetings from eMedi News, Heart Care Foundation of India and Department of Board of Medicine, Mulchand Medcity. Welcome to our show, Chat with Dr. KK. We have with us Dr. Rohit Aggarwal, Assistant Professor of Medicine, Rheumatology and Medical Director, Arthritis and Autoimmunity Center, University of Pittsburgh, USA. Welcome to our show.
Thank you.
The question for the day is very simple. Management of acute gout.
Okay. So the management
First of all, can a patient with acute gout have normal uric acids?
Yes, often.
Often. So what will be the uric acid level there?
So what happens is when you have an acute attack, your uric acid level drops. So if somebody has a uric acid level normally at 9 or 8, they may easily drop less than 6. So the uric acid level measurement during an acute attack has almost no value.
So acute attack of gout is a clinical diagnosis.
Yes.
Okay. Tips for a general practitioner to diagnose acute gout.
So tips for general practitioner to diagnose acute gout is, generally gout is monoarticular. So
single joint,
smaller joint of lower extremity. So typical would be podagra, which is MTP, first MTP involvement. Second most common is the ankle involvement, and third most is the knee involvement. So if you don't get a history of ankle or MTP involvement, then the likelihood of gout is very low. It's an acute inflammatory event. So you have pain, tenderness, redness and swelling. It's so severe that the patient won't even be able to touch it. They say that even the sheet of the bed hurts. So that's how it's acute, and it's short-lived. So it is bad to begin with, but over the period of next few days to within a week, it will resolve. So acute monoarthritis of lower extremities, which is short-lived, with or without treatment, is one of the features of gout that I would say.
Okay, now a patient comes to a physician with an acute gout. What are the options available?
So the treatment is, I will just list all of them. One is NSAID. So indomethacin, somebody said, is a very powerful anti-inflammatory that can be used in a short term for about a week or 2-week course. That should take care of the gout.
No, the patient wants relief instantaneously. He wants relief within 4 hours.
Within 4-hour relief, so the within 4-hour relief can happen if the patient comes to you with acute gout within 24 to 48 hours. Then what you can give is you can give colchicine. And but the colchicine, the way you give is you give 1.2 milligram if the kidney function is normal. And then 2 hours later, you give 0.6 milligram. Then another hour later, you give 0.6 milligram. You do not go above 2.4 milligram in a patient with normal renal function. Previous teaching was that you keep on giving until patient gets diarrhea or the gout gets better. That's no more true, and it's a myth. There are studies which has proven that more than 2.4 milligrams of colchicine is is same as higher doses of colchicine.
What about giving them a shot of steroid at that moment?
That's the best treatment. Giving a shot of steroid, intra-articular joint injection is best treatment for gout.
What about intramuscular steroid?
Intramuscular will work also, and it's also a great treatment for acute attack of gout. And all of these treatment would actually take care of gout
because if you give them allopurinol, it may cause hyperuricemia.
You will never give allopurinol during an acute attack.
Therefore, it has to be given after how many days?
After few weeks, 2 to 3 weeks. Once the gout attack resolves, wait for a week or 2 to completely settle down. Then start
in an acute attack, give them a steroid injection.
Steroid injection, intra-articular or IM. NSAID, colchicine, the way I said, are the 4 best treatments.
So now in NSAID, endomethacin is preferable over naproxen?
Yes, yes. But both are good.
Both are good. Yeah. So we give them either endomethacin or naproxen. So if a patient comes with an acute attack, give them steroid, stat injection, continued it for?
1 injection is good enough if you're giving IM, because IM would stay in the body for long. So if you're giving IM, or you can give oral, a taper of what we do, a 7-day taper of steroid, that generally can take care of.
And then injectable is only once?
IM is only once, because...
So once stat IM, or give them a tapering dose of steroid. Oral steroid, and add colchicine, 2.4 milligram maximum dose. And
NSAID.
So
there's a new drug, I don't know if it's probably not that available in India. It's IL-1 inhibitor, anakinra. That also can be used, which we are using now for acute attack. It inhibits IL-1, which is an inflammatory marker for gout, and it takes care of the gout right away.
Okay. Once the gout is over, and then we start him on allopurinol, or we start it on...
So the typical is I treat gout, bring them in clinic in 3 to 4 weeks. At that time, gout is resolved, and that's the right time to start uric acid lowering agent like allopurinol or Uloric. Now, when we start that, you often want to give something else for prophylaxis to prevent further attacks of gout. Why? Because anytime you change the uric acid milieu of the body, it will precipitate more attack. So, by the virtue of you giving allopurinol or Uloric, you're going to precipitate more attack. Patient is not going to like you. So, you want to tell upfront with the patient that you may get a couple of more attacks before you actually get better. And to prevent those attacks or to decrease the effect of those attacks, we give prophylaxis. And the prophylaxis is either NSAID, which is low dose indomethacin, 25 milligram twice a day or thrice a day is good enough. Or you give colchicine, which is 0.6 milligram twice a day as prophylaxis. I'm talking about all normal renal function for these doses. And the third option is when you can't give colchicine and NSAID, which is typical in a patient with renal insufficiency, we give 5 milligrams of prednisone as a prophylaxis. So those are
is there any role of losartan in uric acid?
So the losartan does decrease the uric acid level, but to treat it is going to be less effective. So
if a patient has hyperuricemia and he is hypertensive, then it is better to give losartan.
Yes,
that is losartan. So what Dr. Rohit says is very clear, that acute management of gout is a domain of everybody, whether it is a family practitioner, an orthopedician or a physician. Don't panic. Treat the gout and don't be liberal in giving steroid. Give them an injectable intramuscular steroid and give them an oral. Start with NSAID, give them for a couple of weeks. Don't start allopurinol at that time, at least for 2 to 3 weeks. Start that later. And so let's thank Rohit for this answering this question. That's all for today. We'll come back with one more topic. Till that, goodbye. Thank you.
Thank you.